was a kind introduction. I hope I can live up to half of it. So this is a real kind of nuts and bolts presentation as opposed to the very erudite ones that we've already had. And so I'd like to just start by saying the real key is to have take-home messages. So look for the kernels that you can use to explain to patients what you're doing, because that's really the value. Most of what I'm going to present you already know a lot about. So how many people have used any chelating substances? See, most of you know a lot about. And how many people are worried about mercury? Yeah, okay, a lot about. And isn't it odd in your estimation that all the other dentists seem to be like lemmings following the same direction and rushing into the sea? And indeed, that's where they end up, is the sea of ignorance and arrogance. And then they want to go ahead and prosecute us for doing things the right way. Always amazes me. So on these slides, I would like to share with you that what we have is an opportunity to review some of these things that have been shared with me by my own observations, by others. Dr. Bruce Dooley, who put together an oral DMPS compound and is not able to be with us today because he's from New Zealand, and so I have his materials as well. And Dr. Doug Quaig, who is with Doctors Data, Dr. Russ Jaffe with the Health Studies Collegium. This is more a collaborative effort than anything, so recognize some of the slides will be slightly set up differently. And in this process, let's see if I can just give you some fun take-home messages. Here's what the human body ought to look like with no toxins. And indeed, just the body happily functioning until, by golly, lead comes along. Now, lead deposits in the bones, in the spine, in the brain, in the kidneys, and as you go through, arsenic hits the liver, the lungs, and the kidneys. Cadmium hits the heart, the liver, the lungs, the kidneys, the gonads, and the bones, and aluminum hits the lungs and the liver and the bones and the brain. And iron hits pretty much all over the brain, the lungs, the liver, the bones, also in the spleen. You can't see it well on this with the whiteout on the slides. And these, incidentally, are not in your records. If you want, we can also make my others available. I wanted to give you a preface to Dr. Dooley's real presentation. Here's mercury. Obviously hits the brain, the heart, the kidneys. Now, those are just the major organs, okay, because you have to know that every cell of your body is susceptible to these toxic metals. When I talk with patients, I explain that the reason they're toxic is because they go in easily and come out slowly, and while they're in the way, they are interfering with your metabolism. And I tell patients, so let me explain your metabolism. It's what you do when you do everything that you do on the inside. So any part of your system can be nailed by these toxic metals. So here's what happens when you start to combine lead and mercury, which I think are the two most dangerous ones that we're dealing with in life. And you start basically hitting all the organs. The liver is slightly spared, but that's all right because we'll catch that when we add the arsenic. And you start looking at this picture and go, everything is getting colored. Yeah, that's true. Also, people have cadmium, another wonderful opportunity to get sick. These slides, incidentally, are courtesy of Ted Rosema, who's one of my good friends in chelation therapy and such. Put this together as an awesome demonstration of how we start to get sick by combinations of things. So let's just add the aluminum, and we're grabbing in more of the tissues, including the skin and other items. Let's add iron, and we've pretty much finished out the organ systems here. And what happens is these toxic chemical exposures are coming from life. People say to me, well, do I have to keep doing chelation? And the answer is, are you eating, breathing, and drinking? Because if you'll stop doing those, you won't have sources of pollution coming in, and we don't have to keep treating you. But the water is toxic, the air is toxic, the food is toxic, and things that we use are toxic. And if you believe that any of the major scientific advances of the 20th century are safe, then I recommend you just stick to Post-it notes, because that'll probably do you less damage than anything. I want to talk briefly about, and just, I know I'm talking to people who know these things. I'm just giving you a refresher course on lethal dose. That's the dose which produces death in a percentage of animals so exposed. So the LD1 would be the dose necessary to kill 1 in 100 subjects. LD25 kills 25 in 100. LD50, the dose to kill 50 in 100. So the LD100 for lead would mean 100 dead rats. The LD100 for mercury would mean 100 dead rats. We do these experiments on rats because you can't get attorneys to show up at the same time in one place. Unless you offer a bonus, of course. But obviously, if you're taking 100 rats and killing them off, you can't use them for the next experiment. So you have to have a new group of rats. Well, let's do something fun. The LD1 for lead plus the LD1 for mercury. So we know we're going to kill 2, right? Unless it's that same unlucky rat that is susceptible to lead and to mercury. Or maybe we'll kill 4 or 6 or 8 because that would kind of multiply the effect, and there's more kills for each toxic metal because the other is present. In actual fact, you kill 100 rats, and this is an amplification. Now, that's what I mean when I show you the pictures of the various metals accumulating throughout the body organs. We're not dealing with just mercury. We're not dealing with just lead, just arsenic. No one comes in so clean as to have just one toxicity. So remember that what we're talking about today is dead rats. We are the rats. And if you remember that, you can explain to your patients, this is why the mercury comes. I love the ones, you told me, I love this, you told me I don't have any problem with toxic metals. What I said was, you don't have a major problem with any of the metals being highly toxic inside you, but you have several metals, each of which makes the others more toxic, and that's why I recommended years before you had your heart attack, stroke, gangrene, whatever, just fill in the blank. That's why I recommended that you do chelation therapy. Well, you didn't tell it to me that way. Oh, God. 26 years of doing this, and I forgot on this one patient to tell it to him that way. Remember, dead rats is what we're dealing with. In the early 1940s, DMPS, 2,3-dimercaptopropane-1 sulfonic acid. I have to use that chemistry phrase so that you know it's a scientific presentation. Was developed. It's a dithiol with 2 sulfhydryl groups. Here's a sulfhydryl, here's a sulfhydryl, and what they do is form bonding with the toxic metals. Now, this was developed as an analog of BAL, British anti-Lewisite, because during the early part of World War I, the British were on an extreme effort to develop something to oppose nerve gases. The nerve gases were specific kinds of acids called Lewisites, and so British anti-Lewisite, BAL, would be the one that would go after the arsenicals that were the most common nerve gases. And at that time it got a name called dimaval, and it's a very simple structure. Peters and Stockin discovered this in the early 1940s when they were searching for this antidote to use against arsenical nerve gases, but they chose to concentrate on BAL because it was easy to produce in large quantities. Okay, now BAL is less sophisticated as a molecule and much more harmful. Okay, it's painful to put in, it's a big time chelator. In the 1970s, some 30 years later, Soviet studies showed that DMPS was effective in the treatment of various heart and blood vessel conditions. And you go, but all we're doing is taking out toxic metals. Yes, because degenerative diseases of our era are nothing but pollution. We don't need heart doctors, we need chelation doctors. We don't need kidney doctors, we need chelation doctors. We don't need gastroenterologists, we need chelation doctors. We don't need dermatologists, we need chelation doctors. We don't need neurologists, we need chelation doctors. Is anybody getting it? Okay. So what is the dentist's role in this? And I think the role is twofold. Number one, you can debulk the patient's exposure source. Okay, so the greatest source is in the mouth. They're carrying it around. They're polluting themselves. And then the second greatest source is going to come from dietary intake sources, water, and so on. The concept is the dentist can look in the mouth, see the problem for a major part of the degenerative disease patterns of our time and say, we need to start taking care of this. We, the dentist and the patient, start. We, the dentist and the doctor and the patient, continue. Because if you chelate out these folks, we do symptom surveys when patients come to the office. They show up and, they're there for a particular office visit, and they've got to fill out a whole page of various symptoms, what's bothering you from 0 to 10. And they start over in the 6 to 10s, and after we've played with them for a while, they're back in the 0s to 3s. And go back to work and go on trips and whatever that they couldn't do before, because degenerative disease is toxicity. And this is a very nice indication that if you just take something that takes out toxic metals, you help heart and blood vessel diseases. Remember, those are the killers of our time. In 1978, DMPS was available for research and clinical use, produced by Heil in Germany, called Dimaval. DMPS was reported most effective in removal of, and look at that little picture slid over there. Sorry about that. I've tried to reposition that half a dozen times. It's most effective in the removal of methyl mercury in the Iraqi wheat disaster, and I believe it was 1978. What happened was we shipped over wheat to be grown, to be planted. Well, if you've got a choice, I can plant this now and eat months later, or I'm hungry now and eat this now. Well, that's okay, except for the fact that it's treated with methyl mercury. And you can talk about acute toxicity from a food source by eating a seed source. In 1983, a potion reported on DMPS and DMSA, two chelating compounds, as water-soluble antidotes for arsenic, lead, mercury, and other toxic heavy metals. In other words, it's just in the last 40 to 50 years that we've really played with an understanding of how you take these toxic metals out. And indeed, removing them is the tough stuff, because when you try to chelate metals, all metals can be grabbed. Okay, physiologic as well as toxic. But it's joyful when you see that these toxic metals can come out by various chelators that you can combine in wonderful ways. In 1983, Hoover and Aposhian argued that BAL, which is the approved military chelator, was 300 times more toxic than DMPS and causes redistribution to brain tissue. And when I talk about the approved military chelator, that really came about because of the Soviet studies from about 10 years earlier. The reason being that the Soviets actually started studying this way back in the 50s, but we only got wind of this as more information became available in the West. They could produce this stuff cheaply, ship it out to the units, and a technician could just go inject everybody. And it didn't require any dosage management or anything like that. Here, you just shoot them all with this. And that's why it was the approved military chelator. Not because it was sophisticated and great, it was cheap and easy. In the mid-1980s, DMPS was used extensively in Europe. Why do we always have to say Europe when we talk about advances in medicine? We have the most sophisticated scientific study base in the entire world, and all of our great advances come from elsewhere. Oh, sorry, I forgot. The politico-economic machine. But anyway, DMPS removing arsenic, lead, mercury, but it has only limited use in the United States. Only limited use because we're being protected from ourselves. We're not being protected, I might add, from putting mercury in, only from taking mercury out. Let me go through that slowly for the Aggies in the audience, okay? 1992, a potion showed that mercury excretion provoked by DMPS correlated well with the dental amalgam scores. With the dental amalgam scores. That would almost suggest that that really is the central pollution point that you're carrying around, and that the reduction in those scores by any means is useful. So debulking by the dental tools is a valuable contribution. People say to me, well, should I not do chelation until I get my fillings out? No, you should be doing both now. Now, very urgent, because people don't know how long they have before they're going to end up with a serious degenerative disease. What do you consider a serious degenerative disease? Anything that impairs your ability to get along every day doing what you want to do. That to me is a serious degenerative disease. You can take all the classical ones, the lupus, the MS, the Alzheimer's, Parkinson's, the general arthritis, heart disease, strokes, gangrene, you can take all those, lung disease, liver disease, kidney disease. Lin and Lin Tan in 2003 reported in the New England Journal on their studies in Taiwan of taking people in chronic kidney failure, non-diabetic chronic kidney failure. Obviously, these guys are going on toward dialysis. And their studies were very simple. They just split the group in half. One half went on to have dialysis. The other half just had chelation. Geez, and their kidney function improved. Now, did they need nephrologists or did they need chelation doctors? See? And what we do is we spend all our time trying to patch up everything instead of go for the root cause. The root cause is right there in this country, in the amalgams. 1995, a patient, he lives here in Arizona. Tucson, is it?
He's in Tucson. Professor at the University of Arizona. He's testified in front of the state on
Perfect.
And everything else. He's been very active.
Perfect.
Very supportive of our groups.
Well, of course, because what we do matters. So, very brilliant research doctor. He showed that DMPS, unlike BAL and EDTA, does not cross the blood-brain barrier, does not redistribute mercury into the brain. Now, EDTA, there's a lot of controversy that goes back and forth. I have been using it for 26 years and have had zero problems with it, but I think it's also because in the last almost 20 years I've used them in combination, and that really does help get things out faster. Whoops. See if I can grab that one back. 1995, a potion proposes BAL and calcium disodium EDTA are outmoded treatments, and DMSA will be used for lead, DMPS will be preferred for lead, arsenic, and mercury. So what I'm giving you is real current information. It's 14 years old. Why is it still under discussion? An interesting question. 1997, Ruprecht prepared the scientific monograph on Dimaval, extensively referencing the European safety and efficacy literature. Again, this is not new. Here's just some structures for you. This is the quick and dirty BAL. You make a little bit of addition here on the sulfhydryl group, stay the same, and you just replace the hydroxyl with a sulfhydryl. And here's DMSA, DMSA. These are just different forms of it. And again, look at the structure. We've got the dithiols, the two sulfhydryl groups. These things go after toxic metals. Now here's a good example. This table is from Kemper, which showed indications and contraindications of chelating agents and heavy metal poisonings. And what he recommended was that for metallic mercury, first choice DMPS, second DMSA. For inorganic mercury, DMPS, then DMSA is the second choice. Organic mercury, DMSA. DMPS is the second choice. Are you beginning to get a pattern that these guys are complementary? Lead, DMSA, then DMPS, arsenic, DMPS or DMSA, okay? And then chromium, an unusual, but seen sometimes toxicity, DMPS. This is really the first choice in a lot of these kinds of issues that you're talking about as dentists. Now, there's been considerable controversy whether the elemental mercury emitted from dental amalgams in humans causes adverse health effects, and whether this mercury adds to the body burden of this extremely toxic heavy metal. So to determine this, they took a look at patients with and without dental amalgams were chosen as the subjects, and they got the amalgam scores, and then they administered 3 100 milligram DMPS capsules by mouth. And that increased the mean urinary excretion over a 9-hour period is what they were measuring. And here's what they found. That if you take a look, well, this is the amalgam folks, okay? And what they found is this is the amount of mercury that was coming out in these folks beforehand, okay? I'm sorry, these are the no amalgam folks. They don't put out much when you give them the capsules over that 9-hour period. These are the folks with dental amalgams in their mouth. They put out dramatically more just with 3 100 milligram DPS capsules in a 9-hour collection. And that's from Experimental Health Perspectives in 1998. Again, this is not new stuff from a potion. So the conclusion that they offered is DMPS can be used to increase urinary excretion of mercury. 2/3 of the mercury excreted is derived from the mercury vapor released from their amalgams. So, the significance of this is like really critical. If you guys don't debulk, we spend a lot of our time just snagging what's coming off those fillings rather than going after the mercury that's already deposited in tissues. So debulking is critical if you really want to advance the patient's recovery. So it says in here the significance and reliability of these measurements can be increased by determining urinary excretion of mercury after a DMPS challenge. If you really want to know whether the patient has mercury, you really do a DMPS challenge test, because any of the others, the vapor measurements and such, just really doesn't give you the information you need. You need the challenge to see it. So, basic toxicology. Exposure leads to assimilation, leads to retention, leads to toxicity. You first get exposed, and then you'll process it in, and you'll become sick with it over time. Acute poisoning versus chronic toxicity. This is an argument that we constantly have in the medical profession. Everybody wants to talk in terms of, they really don't have any problem because the levels in the blood are low. I'm not worried about the levels in the blood. I'm worried about the levels in the tissue, as I showed you on those early slides. It's the chronic toxicity that gets people in trouble. Now, chronic toxicity is a problem because it's not generally accepted as requiring treatment. And yet, this is the cause of the degenerative diseases of our time. So subclinical metal toxicity is what we're really talking about. It's not so obvious that that's the problem, because if it were, then doctors would be taking care of it. So if it's not obvious, it's literally below their radar, hence subclinical metal toxicity. And there we go. So now let's talk about chronic metal toxicity. Subclinical means subthreshold. You're not going to see it readily on the tests, so that's why you have to do a challenge test. And you're not going to see it in what the patient presents with. For a given individual, the reality is that toxicity is exhibited when the level of net retention, that means the amount that goes in compared to the amount that comes out, exceeds the physiologic tolerance. Now, physiologic tolerance is organ specific. This is one of those things where we talk about the weakest link in your chain. Physiologic tolerance, well, let's just kind of say, I only wear the shoe that causes that blister just 1 hour a day. Okay, will the blister ever go away? Of course not, because you're constantly putting in the insult. Well, these toxic metals are challenging the physiologic tolerance, not just continuously, but additively, because every day more goes in. And at some point, the net retention in those cells exceeds the physiologic tolerance, and that's when you first start the symptom set. Net retention is determined by the relative rates of assimilation compared to excretion, and the efficiency of excretion is highly variable. It's determined by protein expressions, metallothiones, glutathione, nutritional status, antibiotic use, lifestyle, and total toxic load. That's the one where you guys get involved. Also, dentists look in people's mouths, as opposed to orthopedists who don't have to examine you, they just need an MRI, and gastroenterologists who don't look at anything on the outside because all they need to do is scope you. Real doctors don't have to worry about you, it's all treating tests. Dentists actually have to look in the mouth. That's where nutrition shows up, or nutritional deficiency. And this is a real point in terms of efficiency of excretion, because if people, because of their lifestyle and their nutritional status, are not doing well, then you can debulk them all you want and I can chelate them all I want, but they are not going to thrive, because physiologic repair is what we're really after. Once you've passed preservation of function, now you're looking at repair. Blood is only a snapshot. It looks at recent or ongoing exposure. That means, you're still sucking on lead popsicles or things like that. The kinetic pools or kinetic models are interesting because the blood pool has the shortest half-life. That means if you don't catch it right away, you don't catch the fact that they just had an exposure. You're now looking at the subclinical thresholds. The relationship between blood lead and after EDTA urinary lead levels are non-linear. So an arithmetic increase in blood lead is associated with an exponential increase in urinary lead. In other words, what looks simple in the blood is dramatic to the body, and that's what you can do is take out dramatic amounts of blood lead. So just in thinking this in terms of mercury exposure as well. Unprovoked urine lead exposure, generally not a useful biomarker to estimate low-level exposure to lead. Okay, but elevated urinary lead chelate complexes resulting from calcium EDTA provide a good means to assess toxic body burden. This is not just for lead. This is for all toxic metals. You want to do a provoked urinary metal challenge, a chelator challenge. Chelators are the drugs approved by the FDA, or not, that allow for going in by one means, either by mouth, by vein, by muscle injection, okay? And then there's some question that transdermal chelators are applicable as well. They go in, they find metals, they pull them out. There's no retention of the chelator, it simply goes out, it's excreted. Most of them in the urine or the bile. And that chelator challenge is absolutely essential. The CDC and some allopaths have recognized the value of the calcium EDTA challenge for lead retention, even for children, where it's given IM, since the 1950s. We can also use rectal suppositories, incidentally, in a variety of patients. You have to be careful what you're doing. It's not just as simple as plunking it up. The precedent has been set, assess the retention of lead and other metals using calcium EDTA, DMPS, or DMSA. Now, you can also use depenicillamine, which I did not have on this slide, but that's another wonderful way of scanning for these things. Pharmacologic detoxification, the push-pull effect, it's primarily extracellular aqueous compartment stuff. We do not appreciably cross a healthy blood-brain barrier. The pull is using a chelator, EDTA, DMPS, DMSA, DFO, and there's a concentration gradient that determines how effectively we're taking stuff out. The intracellular detoxification push is primarily from glutathione, although some of the other internal molecules are probably doing it, and it takes time for re-equilibration. So what you want to do is pulse these doses, because you're not going to get everything out just because it's there. You have to equilibrate, reestablish concentration gradient, and so on. DMPS is the official drug in the Soviet Union since 1958. It's registered with German health authorities. The half-life is about 9 hours orally, about less than 1 hour IV. It has minor penetration into the red blood cells. Here's mercury before and after a DMPS challenge. In dental techs, before was 5, after 424. In dentists, before was 3, after was 162. Controls by example, before was 1, after was 27. This is after a 300 milligram DMPS oral challenge. Do your techs and do yourselves need to be considering whether your exposure is ambient as well as in your mouth and in your food source. IV DMPS provocations in autism spectrum disorders. Here's arsenic, lead, mercury, tin, cadmium, and nickel across the bottom. Here's the befores and the afters, and the befores and the afters, and the befores and the afters. Look at these massive amounts that are coming out in terms of toxic metals in all these kids. All these metals. Interesting. DMPS possible side effects. Rare is a severe allergic reaction. Mucocutaneous eruptions can occur. Those are the most frequent things that I've seen, is a rash on the outside or in the mouth. Chills, fever, exanthema, itching, skin rash. Presumably these are mild allergic reactions. All of the ones I've seen have been mild. They go away when you stop using the drug. Elevated transaminase levels, never seen them. Hypotension, nausea, dizziness, and weakness, usually from the IVs. Depression, brain fog, and fatigue are possible. This is why IV is not a recommended situation. You can get copper, zinc, and molybdenum deficiencies. That's why you do this by paying attention. You don't just give them the drug, you give them the support nutrition as well. There's no documented Stevens-Johnson syndrome has been reported and proven from DMPS, although that's always a question. Antioxidant effects of detox agents, EDTA, DMPS, DMSA, are free radical scavengers, a critical part of how they work. They decrease the oxidative stress inside the system, and they increase hepatic glutathione in lead-exposed animals. Hepatic glutathione, your primary detoxifier in your primary detoxing organ. What a thought. So these things matter. These are in the literature. This is not, speculative. Antioxidants are a must for cellular protection because DMSA, EDTA, lipoic acid, N-acetylcysteine, E, C, melatonin, and taurine improve the redox state of the cells, increase the glutathione, and decrease the biomarkers of oxidative damage. The more we look at, when we look at these antioxidant activities, every time we turn around, we get greater metal excretion with DMSA plus antioxidants. That has not been looked at, to my knowledge, with DMPS. But we saw in the beginning how similar these two compounds are in what they're after, and they're almost interchangeable in what they can be used for. So it's easy to speculate. So, first half of this talk, take-home messages. Apply the pharmacokinetic facts. In other words, these are real, they do work, and it's how you use them is determined by how they actually do work. Calcium EDTA by vein is very effective for lead, cadmium, and aluminum. It's also effective for a variety of others. Rectal calcium EDTA is not optimal for challenges, but effective over time therapeutically, but it has a number of potential drawbacks for long-term use. Obviously, this isn't that kind of discussion, but we can go into it if you want later. Rectal DMSA is effective for challenges and detox, and you need pre- and post-rectal DMPS data to really know what the DMPS story is. IV and oral DMPS are very effective as chelators. IV and oral DMPS. So let's talk about the oral one because it's much safer. Calcium EDTA, DMSA, and DMPS have dual actions. They are both antioxidative in their immediate effect, and then they detoxify the metal as well. So you're getting a nice double whammy. These agents work best when they are combined with natural antioxidants. That's why you pay attention to nutrition, vitamin C, vitamin E, and so on. DMSA is not a nutritional supplement. It's sometimes marketed as such. It is not. And equilibrium constants for DMPS metal complexes are kind of fun. Look at the log K for Mercury 2+, 27, the K1 and K2, 36. These things really, when they bind, they hold on. Here's methyl mercury, 21 and 31. Much less for any of the nutritional metals, 15 for zinc and 25. These things, once they find mercury, really like to hold on to mercury. EDTA stability constants, here's one for lead, log K of 18, nickel 18, and you can see that really what's happening with DMPS is it is holding very tight. So the metal chelators of choice for inorganic mercury would be DMPS, for organic mercury would be DMSA or DMPS, and then if you look down the rest of the chart for lead, arsenic, cadmium, and so on, you see DMPS is listed on there as a first or second choice continuously. This is a momentary stretch break while I put the other one on. Sorry you missed it. I said momentary. I didn't guarantee a long one. But I'm going to take a sip of water so you can have a stretch. Okay. Mercurialism. You've not heard of that disease, I'm sure. But we're finding and eliminating the hidden beast. Now, in this talk, we're going to talk about really what is modern information because you can use this very wisely now. And in terms of heavy metal toxicity with emphasis on mercury, there's the Integrative Medicine Clinicians Journal from April and May of 2007, which has a nice review in there. And in that, they talk about mechanisms of metal toxicity. Metals generate many of their deleterious effects through the formation of free radicals. Now, free radicals are the oxidation chemistry. I tell people you rust on the inside just the same way a nail rusts on the outside. And so we call that oxidation chemistry, and that's why we have antioxidants called vitamin C, vitamin E, and so on. But the importance of having the toxic metals in there is free radical oxidation reactions can proceed 1,000,000 times faster in the presence of toxic metals. So getting those out is important for anti-aging and for slowing the rate of degenerative disease progression. Now, this is important because if you take a look right here, free radicals and DNA damage. Has anyone ever heard of cancer associated with DNA damage? And when I say that toxic metals, that pollution is the disease, the degenerative disease of our time, cancer, I think, will largely be shown almost exclusively to be the result of toxic metals and toxic chemicals, organic chemicals primarily, because we're looking at DNA damage systems. Now the problem is, I don't know how well that's going to pay or play in the cancer hospital system. So we'll probably still need all those toxic chemotherapeutic agents rather than prevent the cancers of our time. Lipid peroxidation, you know that as rusting inside your blood vessels and such, also in your nervous system. Depletion of protein, sulfhydryls, glutathione is absolutely critical. How many people do you think have adequate glutathione levels? Almost none. Now, if you had adequate glutathione levels, it's because, number one, you started out genetically well, you were raised well and nutritionally well fed, you are still nutritionally well fed. That obviously is not what food is available in the standard diet, okay? And you do not have toxicity exposures, because in the last 50 to 60 years we've poisoned the planet, which dramatically increases the inherent need for glutathione way beyond what we physiologically are capable of producing. So those kinds of things like this look like just a little sentence on the slide. That's how we get sick. There's your Parkinson's disease sitting right there. And metals are everywhere in our environment, and exposure from them is inevitable. Oh, well, I have an air purifier at home and I drink bottled water, I buy organic food. So, explain to me, if you do all these things, how did you get sick? Why does your toxic metal profile show all these toxic metals? Well, I don't know. I know you don't know. I do. You don't. That's why you're with me. Metal toxicity creates multi-system dysfunction. You know, you don't just come into this is what's wrong with the specialist orientation in modern medicine. You need to be a generalist, because am I going to just treat you for where this mercury has harmed your kidneys? Or am I just going to treat you for where this mercury has harmed your brain? Well, no, I'm going to treat you for the mercury that's harming your body, and all those things start to get better at the same time. Therefore, you don't need the neurologist, you don't need the nephrologist, and so on. This is where modern medicine has parsed it out so much, you can't get people better. That's frustrating, isn't it? Because what we're talking about is mitochondrial damage from glutathione depletion. Mitochondrial damage. All the cells of your body except the red cells have energy-producing jelly beans called mitochondria. If you damage those, you damage the work of the cell. Eventually the cell is not working at all, it is just struggling to stay alive. We would call that asleep. It then stumbles into comatose, then it stumbles into death. We call death, you now have liver disease. Look at the levels in your blood. So in other words, modern medicine waits till you're dead on the inside before it can identify that you're sick. What an interesting thought. It's almost like we've got to arrive in New York to actually believe we took off from Phoenix to fly there. Well, you know, I kind of think if we've been flying for 4 hours, we're getting close to New York. Yeah, but we don't have any tests to measure that because they don't look for it. And I can tell you that if doctors don't look for disease, they cannot see it. Mercury, toxic to all living creatures. All, any, all, every. Everywhere in the environment, we have managed to scoop it up where it was and put it everywhere else. Increasing health damage if not removed. This is an accumulative thing. Not only are you constantly putting in more, especially if you have amalgams, but I mean, you know, the food in the environment is increasingly dangerous, so you're going to be eating that. And remember, it's going in but staying. So it's not just affecting processes that are starting to wear out nutritionally, just because time has passed. You're physiologically not replacing yourself, but you're accumulating more and more. So more of it is going into an increasingly challenged system that's having a hard enough time just keeping going. That's called natural aging. See, natural aging is a disease that happens one day at a time, and that's associated with free radicals and physiologic deficiencies, and the fact that, genetically, the telomeres and all that stuff that we talk about, we may just have preset aging patterns. That's a good idea, otherwise the world will be overpopulated with all those folks in Florida and Arizona. Yes?
I'd like to share with the audience that I'm treating John's father, Jack, who's 92 years old.
91.
91?
91.
Soon to be 92.
Yes.
Who chelates all the time.
All the time. My dad has had over 500 chelations, and that's over the last 26 years. Dr. Biles is happily working on a tooth back here that he wants to preserve because he's lost many others. My dad was an Air Force bomber pilot, so, it's the high stress, high altitude, high alcohol, high tobacco, all that stuff, and to which he has added high age. And
He's a lot of fun.
he is a lot of fun. He's great. He lives by himself, and thank God takes care of himself.
How old is he?
He's 91. Yeah, he just came to stay a few weeks with me to get his cataracts done. That ended up being 2 months because 90-year-old hard-hitting cataracts are hard to heal.
Did he drive out?
He just drove home. Yeah, on Wednesday. Yeah. So you get increasing health damage if the mercury is not removed. It may take years for symptoms to appear because God has blessed us with the resilience of a system that just kind of keeps on going. If you're short on something nutritionally, you don't stop. You just slow, And eventually you go, you'll find an external reason for all that. You won't find a toxicity reason. The first place you look is the last place you do. It causes many diseases. It blocks healing, and mercury is usually hidden as the cause. And especially, I love the way doctors say, I've never really heard anything that chelation therapy does well. Yeah, because you do this every time someone mentions it. All right, mercury affects every body system, the nervous system, the emotions, reproduction, heart, kidneys, hormones, sexual performance, vision, gastrointestinal system, immune system. In children and fetuses, this is the real tragedy, of course, because we're supposed to be responsible enough to protect the upcoming generations. Now, if it affects every body system, do you need a specialist for every one of those systems? No, you need to remove the mercury. Let's start at the beginning. I mean, how many times do you pick up a book and go to the later chapters because that's where the specialists are? Let's go to the beginning. Oh, did you see that?
Pretty fast.
Yeah, I hope I can get it again. Let's see.
I didn't see that in dental school.
You didn't see that in dental school? Let's see if this will cooperate for us. Recent studies suggest that mercury may have no threshold below which some adverse effects do not occur. No threshold below which. No. How close to a grenade is safe? What a thought. So we come into contact with mercury from amalgams, the number one source. And the third most common source, again, is amalgams. Okay? Are we getting that? Does anybody in here use any mercury? Well, now, come on. You can polish dimes. It's good. Thermometers, polishing dimes. I mean, there's a lot of good uses for it. That's right, the new light bulbs on safe, and those little switches on kids' shoes, that light the shoes as they're walking and stuff. The mercury's all over us, okay? It's in your computers, it's in your monitors, all this stuff. But the number one exposure remains amalgams. Then fish. Oh, vaccines. Oh, you can scratch that. The federal court said that doesn't matter. You know what you call an attorney who scores highest in his class?
The valedictorian.
The valedictorian, yes. And he gets to go to Wall Street and make $1 billion or several billion in bonuses. You know what you call the attorney who has the lowest passing score in his class? Judge. Thermometers, fluorescent bulbs, thermostats, barometers, light up sports shoes, cosmetics. God, you look pretty, but I don't want to kiss you. Disinfectants, skin creams, tats, latex paints before 1991. You know what you use in latex paints now is arsenic. Yeah, that way you don't get mold. Okay. Blood pressure gauges, button cell batteries. I mean, it's just all over the environment. Okay. Amalgams, daily intake, 3.8 to 21 micrograms. Fish, daily intake about 3 micrograms. Other foods about 3.6 micrograms. First, second, and third is amalgams, and amalgams, right? All right, the amount of mercury vapor released from amalgams. Chewing food, 68 micrograms per square or cubic meter. Toothbrushing, 272. Placing the amalgam, about 2,000. Removing the amalgam, about 4,000. Polishing it, about 4,000. So does it make sense that you guys might want to be protecting yourself? Because this is where the dentists scored higher on, dental techs and dentists are constantly doing this kind of stuff. That's where you guys get your exposure. So 1 tiny little microgram of mercury equals about 43, that number, million atoms of mercury, because it just gets bigger, because one large amalgam is 1 million micrograms of mercury, and that just means basically that we're looking at 43 blah 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 atoms of mercury. Okay, where do you think those atoms are heading? Where do you think they're on the way to? Your brain and the rest of your body. Okay? This is degenerative disease happening as we speak. This is where we get toxic. This is where we are bioaccumulators. It's not good enough to be a bioaccumulator, where we eat the cows that ate the grass that was poisoned with something and they accumulate, so we accumulate more from them. We're putting it in, just in case you didn't eat enough bad stuff, like fish and whatever, okay? This is degenerative disease happening. Worldwide, there's over 4,000 research papers indicating mercury is a highly toxic substance. This is a hard thing to keep track of because it keeps going up. How can dentists be so thoughtless as to place one of the deadliest toxins in existence 2 inches from our brain? Well, it pays well. That's what we were taught to do. Remember, we were taught to do that, like lemmings to the sea. We were taught to do that. What's that?
First we were put on fluoride to make us follow.
That's right. Fluoride's first. That's right. Dumb you down, and then we can make you do whatever we want. That's right. Amalgams and urine mercury. You look at the number of amalgam surfaces going up, and you start getting into a log phase to increase the urinary mercury excretion. This just is so much fun because it just goes up, up, up. You'll notice it's not quite arithmetical. It starts turning logarithmic. All right, University of Calgary smoking amalgam. I hope this will play. And it might not. We had hard enough trouble this morning, didn't we? It won't play. All right, fish are a source of mercury as well. There's fish. And if you'll notice, you get bacterial detoxification, and you get this mercury coming out as methyl mercury going into the water, and you've got organic mercury and all this stuff. Unfortunately, this did not enhance and enlarge very well for your precipitation or your views, but basically fish and birds, all the shellfish, all the life, everything is getting contaminated constantly, and bacteria are doing the methylation source in the wild. Makes it much more toxic. Coal-fired power plants are the top U.S. mercury air polluter. Do you know where they are? No! Beijing. Do you know that they're turning on one new coal-fired power plant every week for the next 10 years? So, that's, say that?
Without scrubbers.
Without scrub. For what? What do you have to scrub? You just blow it up in the air. Life is good. Okay? So, that's why they had to turn everything off when they had the Olympics there, because it's so murky. But, we've got our share of power plants, and they're using scrubbers. But 8,000 tons of mercury pollution per year. 8,000 tons. We're talking some serious mercury levels here. Study linking 38,000 heart attacks per year in the United States. There's probably far more than that, because how many people are really checking? 450,000 river miles and 12 million lake acres are polluted with mercury. Every state in the United States, every state has fish consumption advisories due to mercury. Every state. For the Aggies in the audience, that means all them fishes. I'm tough on Aggies, but not unreasonably so. Isn't it wonderful when a tea sipper from the University of Texas gets the mic? Isn't it just great? I love it. Occupational exposure to mercury, okay? You will recognize that, Chair. Mercury is a double-edged sort of attack. The direct attack is mercury attaches to any protein or enzyme with a sulfhydryl group, destroying its function. Why does that matter? Because sulfhydryl groups are the center of enzyme activity. You know, sulfurs and oxygens have this one, and some, to some extent nitrogens, have this wonderful ability to flip around electrons and play with other folks. They do play well with others until they find one they really like, and then they don't play well with anyone else. They got married, do not know how to get divorced, so they're stuck. Okay? And so sulfhydryl groups are the active sites in enzymes. In other words, if you do your job, you're using sulfhydryls. If mercury finds a sulfhydryl, you no longer do your jobs. That's what metabolism interruption is all about. The indirect attack is it weakens the immune system while depleting the body of glutathione and selenium. Selenium and sulfur are the two things that these toxic metals really go for. And let's see, mercury is escorted out, not broken down. Mercury can never be detoxified by the body because it can't be broken down. It's got to be grabbed and taken out physically. 2 glutathione molecules are lost for every atom of mercury removed. Millions of atoms may be removed daily, and glutathione depletion is not good. How many people are familiar with David Perlmutter's work on glutathione and Parkinson's? It's absolutely wonderful. I mean, it's just absolutely miraculous. And you start doing IV glutathione, and these people start walking a whole lot better, and then you shift them over to oral glutathione and see how much you can get past the need for IVs. And it's absolutely spectacular work. Selenium. 2 complexes between mercury and selenium are less generally known than that of mercury and sulfur, but they are of much higher affinity. That means when it finds selenium, you no longer have it. Of course, that's not important for heart health or anything like that. Mercury selectively binds to selenium, forming mercury selenides, thus reducing mercury's damaging cytotoxicity. Now you've got to get rid of the selenite. It's been known about since 1967. This is not new information. Like glutathione, selenium availability for many other important enzyme reactions is reduced. Leads to many health effects, including cancer. The Journal of Neurochemistry in January of 2000 talked about concentrations of heavy metals, including mercury, been shown to be altered in the brain and body fluids of Alzheimer's disease patients. Alzheimer's disease. Alzheimer's disease associated with aluminum, associated with mercury, certainly amplified with the effects, remember the dead rats, by the presence of lead, and so on. Now, is it beginning to give you the idea that degenerative disease is pollution? Degenerative disease is toxicity? It is not organ-specific disease. It is body-specific disease. Tau phosphorylation was significantly increased in the presence of mercury. That's the breakdown products in the brain there. Those results indicate that mercury may play a role in pathophysiological mechanisms of Alzheimer's disease. Don't you love the way science can't ever determine anything? You know, it may suggest that the sun rises mostly in the east sometimes. Further studies being necessary. I want to apply for that bailout grant where I can just sit and watch and confirm whether it comes up every morning for the next 10 years in the East. The relationship between mercury from dental amalgam and the cardiovascular system, 1990, not new information. The data suggests that inorganic mercury poisoning from dental amalgam does affect the cardiovascular system. Really, we're talking about chest pains, fast heart rates, anemia, fatigue, and then tiring easily, being tired in the morning. Certainly that does not explain the American way of life. Mercury directly causes atherosclerosis. This is from 2007. Mercury activates an enzyme called phospholipase D in cells that lie in the arteries. This causes the release of phosphatidic acid, damaging the endothelial cells, requiring you to put a cholesterol patch on there because you don't have enough vitamin C and vitamin E to defend yourself, and that's where the plaque formation is starting. The treatment? Chelators overall did a better job than antioxidants at protecting against mercury activation of the enzyme. Yeah, well, chelators and antioxidants are awesome. The problem is that just like glutathione, you need to have vitamin C and vitamin E present at the time of the free radical formation, because you're talking in picoseconds that these things are flitting through doing their damage. So if you don't have enough, you don't have enough. You've already done the damage. Don't worry about that. The only thing you can work for is the future. The Frostasi study, Journal of the American College of Cardiology, 1999, marked elevation of myocardial trace elements in idiopathic dilated cardiomyopathy. This means we can't explain it. That's the idiopathic part for the doctors. Dilated cardiomyopathy means your heart's getting floppy and large and it just don't work right. The myocardial and muscular content of 32 trace elements was assessed by biopsy sampling of 13 patients with IDCM. Large increases, 10,000 times greater for mercury, was observed in myocardial but not in muscular samples in all those patients. 10,000 times or more concentrated in the heart. Do you think that matters? The mean of mercury in all 13 of those patients was a 22,000 times increase. 22,000 times beyond what the muscles themselves are getting. Mercury twists the emotions. People get indecision, low self-esteem, shyness, timidity, overwhelming feeling. Anybody in this economy feel overwhelmed? I mean, just listen to the news all the time. Whoa, I lost that one. Lack of joy and humor, just listen to the news. Hopelessness, the news. Lack of motivation, the entitlements. Depression, those of us who are paying for the entitlements.
Government and Mercury together, huh?
That's it. That's how it works. That's why your Congress doesn't have to read a bill to vote on it. They just intuit. Okay? It hasn't hit that part of their brain yet.
Muscle test.
That's right, we can do some muscle testing, that's it. Fearfulness, anxiety, panic, impending doom. Yeah, okay. Irritability, aggression, inappropriate anger, and rage. All these things are mercury-associated twists on your emotions. This stuff matters. This is scary stuff. The fact that it won't go to the next slide is scary. There we go. Mercury disrupts the brain. Lack of focus. Brain fog. How many people just say, no, it's kind of like it's just foggy. Forgetfulness. Memory problems. I mean, this is what people come in their 40s and 50s complaining of. Dementia. Mercury harms kids. Kids, poor babies, affected in the womb with breastfeeding, irritability and emotional problems, attention deficit and lower IQ, autism and vaccines. Is there any evidence of harm? Certainly not. How about no kids at all? 16% of the couples are fertility problems. Mercury creates hormone havoc, causing fatigue and weight gain, causing low sex drive. It's a common complaint. Cold extremities, impotency, another common complaint. The little blue pill, right? Insomnia, hair and skin problems, mood swings. That does not mean PMS. I'd like to clarify that. Mercury mangles the immunity with lower resistance to infection so that we can get scared about superbugs, and prolonged infections so we can get scared about the fact we paid $200 for an antibiotic 3 times. Allergies and autoimmune diseases like lupus and rheumatoid. It has mutagenic effects, which means that you start getting sick. Your cells get sick all over, your defender cells, your nervous system. You get frequent chronic headaches. Certainly not a problem. You don't need Tylenol PM or Advil PM when 10 PM should be enough for sleep. Frequent headaches, tremors. It affects all 5 senses and neurodegenerative diseases. Any neurological problem, suspect mercury. It's also a heartbreaker. 20,000 times more concentrated in the heart tissues, as we saw in the dilated cardiomyopathy, angina, arrhythmias, heart attacks. These are the things that kill us. Heart failure, again, another common episode of our time. The physician's duty to the patient, well, his not considering mercury is a failure. Because what he's done, and when it says first do no harm, if you don't look for what's causing the problem, you've just done harm. And that's a very scary problem, because we have a hard time getting regular doctors to believe that this is that important. Not to consider or rule out mercury is that critical. Life is what we're here to enjoy. How can you know where you're going if you don't know where you are? And that's the problem that modern medicine finds itself in, and sadly, except for groups like this, modern dentistry. The patients have depended on us. We have failed them. Testing the body burden of mercury happens really quite simply. It's inaccurate to use blood, urine, and hair. Okay? It is accurate to use a DMPS urine challenge test. We saw those data earlier. Why? Very simple. Because urine mercury provoked by DMPS challenge will show far higher levels, and then will actually document why you need to be doing what you're doing. Get that debulking done. Townsend letter issue on mercury toxicity and related disorders in June of 2007. Dental mercury poisoning, the safe removal of amalgams and oral detoxification programs. A wonderful reference source. June 2007, Townsend letter. You can still get those. Here's an assessment of body toxic metal body burden by David Quigg, whose slides I was showing you earlier. And he talks about how important these are. The basic model of toxicology is logical, but needs to be applied in an updated and preventive context and not crisis management. Exposure alone should not be used to make diagnostic decisions about chronic toxicity, but a quantitative assessment of net retention, what we were talking about earlier, provides the clinician with objective, arguable data. The argument, of course, is with the insurance company. But the objectivity, the patient feels it all the time. The patient doesn't worry about objective. He worries about whether the objective relates to his subjective. I tell patients all the time, all I'm doing is telling you a story. If my story is right, we might get the right answer. We might get the right answer accidentally, but it's going to be closer if my story is right. So that's what the objective data do. Provocation testing. Currently, the best approach to assess the net retention or body burden of toxic metals is your analysis after administration of well-established chelators or metal-binding agents such as EDTA, DMPS, or DMSA. The provoked urine challenge. That's the key. Here's a 54-year-old female dentist with progressive weakness, fatigue, polyarthralgias, memory decline, and anemia. Maybe one of your friends. And here's a blood mercury level. We don't have to worry about it because blood mercury is less than 10, so it's not a problem. It's okay. And here's a provoked urine mercury. You will notice it's way off the chart. Okay? 2-hour timed collection. Twice. 37-year-old with chronic fatigue syndrome. There's her mercury level right there. And that's in the hair. Hooray, she doesn't have a problem. Oops. 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 What if we go looking at her urine challenge? If I can get it to come up. There we go. Here's her mercury and the urine challenge. Can you see why you have to do the provoked urine challenge? Oh no. I love these little things here. Test results you can expect from your patients. Everybody sitting down. Are you ready? Of 800 provoked urine challenges performed by MercOut International, Bruce Dooley is the president of that group. I'm one of his state coordinators and brain trust, I guess. On a healthy individual group from 18 to 70, 70% showed very elevated findings on the urine challenge. 70%, and for those of you who missed it the first time and second time, 70% showed very elevated. Do you think that that is degenerative disease developing right there? But 25% had only elevated. Thank God, only elevated. 5% were within a reference range. Reference range means we still consider a little bit of mercury isn't that bad. Whatever. So now that you've seen that you or your client or patient has toxic tissue mercury burden, what's the next step? Well, you got to get it out. DMPS is, without doubt, the best mercury chelator. There's a 50-year history of safe use. IV, not recommended. Oral, it's very well absorbed orally. It's effectively binding to mercury, lead, and arsenic. 6 times more effective than DMSA. It has a very low toxicity. It's not available over the counter. What you have to do is be a professional prescribing it. And IV problems. Remember that. That when you hear, oh my God, DMPS, I've had such problems with that, that's the IV form. Very rare to have issues with the oral form. Mercury levels falling with oral DMPS over time, over days, dramatic decreases. A 30-day at-home program is what Dr. Dooley espouses. Its exclusive formula targets mercury, arsenic, and lead. It's safe, it's effective, it's physician monitored. It's equivalent to about 8 IV treatments at certainly a fraction of the cost. And again, I don't agree with the IV DMPS. I think there's real problems. And at the luncheon, we can talk about more specific protocols that I've adapted and changed, because adapt and change everything. And that's easy. Here's a New Zealand, United States clinical trial. The objective was to determine the availability of oral DMPS to provide both accurate detection and removal of tissue-bound mercury. Remember, detection is when you prove to the patient he's got it. Removal is what you do about it. Okay? By comparing pre- and post-treatment urine mercury by DMPS provocation analysis. They took 147 people in the New Zealand and the United States in medical centers. They were based on documented tissue burden of mercury by the provocation test. So we knew we were dealing with mercury patients. The baseline quantitative analysis was compared against repeat provoked urine following 1 to 2 months of therapy. So it was the oral DMPS plus a nutritional support formula given once daily. The dosing was 100 milligrams, eventually progressing to 200 milligrams in those patients. 63% of the cohort showed reduction of measured urine mercury levels greater than 50% within 30 to 60 days. The average mercury reduction was 69%. There's the product. I whited it out for you. I blued it out, I guess, just for ease of showing you that the actual DMPS pills are these dark ones. These are the nutritional support pills. You take these in the morning, these in the evening, and you get a packet, a blister pack set that takes you for the month. 30-day program equals 8 of the 250 milligram IVs with dramatically less side effects. Every patient in every practice can benefit, because remember, degenerative disease is a disease of pollution. It is not organ specific, it is body specific. So when you introduce mercury testing and treatment, your patients benefit from a program that is safe, effective, proven, convenient, cost effective, physician monitored. Oh my gosh, we must be talking about putting in dental amalgams. No, 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 unfortunately, because we would have stopped it a long time ago if we really could accept the data. So the deal is that what we've got is clearly a problem. Y'all are aware of it. This is nothing new. Clearly a treatment, which you might not have been aware of, and this really does help people feel better. So the good clinician protocol is always consider mercury in your health assessment. For those of you who are Aggies, I'll repeat that 2 more times. During the mouth exam, record the number of amalgams and gold fillings. If there are no amalgams, ask if they were removed, when and how. When and how, really critical. When indicated, order the DMPS provoked urine challenge. Detoxify if the test returns with elevated or very elevated mercury. I would further go on to say that if someone is, quote, within reference range, I'd make sure that every year or 2 that test is repeated, so that when they finally get enough mercury exposure from their environment, you're on top of it. Suggest a safe amalgam removal after detoxification. That is Dr. Dooley's viewpoint. I feel that we can do it during detoxification. Recommend ApoE testing if there's a family history suggesting heart disease patterns. Be careful of fish choices. For those of you who are Aggies, that means all them fish. So the conclusion of the educational program is very simple. Dr. Dooley says, I believe one day it will be the standard of practice for every healthcare practitioner to consider and rule out mercury as a causal toxin in their client or patient. Now, I would go further and say mercury and lead and arsenic and such because of the dead rats. Okay? The idea being very simply, we can do a much better job of taking care of people if we are buffing and polishing out the scratches rather than trying to bondo in all the crunches from the accidents. Modern medicine waits for the accident to happen instead of putting up caution signs. So what we have to do as the standard of practice is take care of our patients. Dr. Dooley noted, my commitment is to educating people about the health hazards of mercury and providing an economical and effective means for its detection and removal from the body. And I think he's definitely done so with his Excellent, excellent program. This is a new dawn in medicine. I would encourage you to get involved. I do have some papers with me if you're interested in getting more information from Dr. Dooley. I'll even have more at the author's table tonight. And you guys have been a wonderful audience. Thank you so very much.